We looked at PK/PD of vancomycin and determined the vancomycin loading dose for critically ill patients with serious MRSA infections. Now the next learning objective is, given a patient with a suspected MRSA infection, recommend IDSA guideline-concordant empiric vancomycin maintenance dose and frequency. These recommendations are from the 2011 IDSA MRSA guidelines, and these are intended to make recommendations more straightforward, and they do not depend on pharmacokinetic equations. So there are no equations involved when you recommend a vancomycin dose following these recommendations from IDSA. So basically they recommend that for IV vancomycin you can use between 15 to 20 milligram per kilogram per dose, and that's using total body weight as the body weight. So once you determine the dose, then you determine the frequency. That's typically every 8 to 12 hours in patients with normal renal function. And they recommend not to exceed 2 grams per dose. So if someone is obese, they recommend not to exceed 2 grams per dose in order to avoid the nephrotoxicity. And then they recommend to get the trough prior to the 4th or the 5th dose. And then once you get that level after or I should say prior to the 4th or the 5th dose, they recommend to a target trough of 15 to 20. So the higher end of the trough, 15 to 20, for serious infections such as bacteremia, endocarditis, osteomyelitis, meningitis, pneumonia, and severe skin and soft tissue infections such as necrotizing fasciitis. And of course, any of these, as long as they are due to MRSA. And so anytime you use the 15 to 20 milligram per kilo, most hospitals round to the nearest 250 milligram. So for example, if you calculate 300 milligram, you're gonna round it to 250 milligram. Or if you calculated it to be 1200 milligram, you round it to 1250. So whatever is the closest next 250 milligrams. So these are estimation, and then you will find out if this was the right dose or not prior to the 4th or the 5th dose. And the reason they recommend prior to the 4th or the 5th dose, that's the closest to the steady state. So they want you to adjust the dose based on the level from steady state, because if you get a level too soon, it's gonna be subtherapeutic, so you're gonna increase the dose, and then by the time level is at steady state, it will be supratherapeutic, and then the dose will be too high. And then the way you can choose the frequency is based on renal function. So in someone with excellent renal function, meaning creatinine clearance greater than 90, you can actually do every 8 hours. And of course, these recommendations are in adults. And then in patients with creatinine clearance of 50 to 90, you can do every 12 hours because it takes longer for them to clear it. Unless if they weigh actually more than 100 kilo, then you can do every 8 hours to keep those daily doses smaller. With creatinine clearance 15 to 49 every 24 hours. And then with end-stage renal disease, you actually want to do PRN, or I should say as needed dosing. And what that means is that you actually give a single dose and you don't give it the frequency. You just say it's as needed, and you just check a random vancomycin level in 24 hours after the dose, and then if the level is less than 20, then you give one more dose, and then you keep doing this every day. Whereas if the next day, because the kidneys are not clearing it, if the level is more than 20, you actually hold the dose and you repeat the random level in 12 hours. Now, this is one way of doing it. Most hospitals actually have protocols on how to approach this. So you may, depending on what hospital you work at, you may see a protocol that's slightly different than this. But generally speaking, these protocols do PRN dosing of vancomycin in end-stage renal disease. With dialysis, it's also PRN dosing, because on certain days where hemodialysis is not done, on those days, chances are that the level would be greater than 20, and you just hold the dose until the day that they get dialysis. And I'll explain more about hemodialysis in a little bit. Now, in the 2020 ASHP IDSA vancomycin guideline, basically they make the same recommendation of 15 to 20 milligram per kilo per dose using total body weight every 8 to 12 hours in patients with normal renal function. And they do say that trough only monitoring with a target of 15-20 is no longer recommended. They say that the most accurate and optimal way to manage vancomycin dosing should be through AUC guided dosing and monitoring, specifically targeting individualized AUC to MIC ratio of 400 to 600. And this is empirically, since it takes some time for MICs to come back, empirically we just assume an MIC of 1, because for the most part more than 90% of MICs in the United States are either 1 or less, so it's unlikely to have MIC of higher than 2. And then of course if we get the MIC of 2, we actually will not be able to achieve these targets using the traditional dosing of 15 to 20 milligram. Now for the monitoring, they recommend that vancomycin targeted exposure should be achieved early during the course of therapy, preferably within the first 1 to 2 days. And we will cover more details of how to monitor AUC to MIC in learning objective number 7.